So make a start. Hi, everyone. Can everyone hear me well?
Yes.
Yeah.
Okay, thanks.
Hello, everyone.
I'm Nisima Chowdhury. I'm the Learning Disabilities and Autism Project Manager for North East London. Welcome today to our annual health check webinar around letter reviews. I'm going to introduce my co-host, Dr. Sood, if you'd like to introduce yourself.
Yeah, thanks, Nisima. I'm Jyoti Sood. I'm the clinical lead for NEL Learning Disability Workstream, and real warm welcome to you all to the first series of webinar that's planned to improve the care and the quality of patients in NEL with learning disability. Actually, it's really, really good to see cross-sector and cross-NEL and a truly multi-professional audience here today. The webinar today will provide an overview of the key findings from the leader report, an update on the annual health checks, and go through the DES requirements. The team presenting here today is all part of the Learning Disability Board and have got extensive experience. We are planning to collect the questions and answers, so it's 45-minute discussion or really talking to you, and then there'll be 15 minutes for Q's and A's. We hope to take some of the questions and suggestions away and build a booklet really that we can share widely. Of course, we'll try and answer as many questions as we can today as well. So warm welcome again. And with that, I'll ask Chi if she could share the slides. But before we do that, can I just do a quick round of introductions to the team here today? Just because I can see Binny here first. Binny, can you introduce yourself?
Hello, everyone. I'm Binny Thomas. I am a consultant psychiatrist for adults with learning disabilities in Havering and the Associate Medical Director for LD Services in NELT.
Thank you, Binny. Rachel, would you like to come next?
Thank you, Dr. Sood. Afternoon, everybody. I am Rachel Penny, and I am the Learning Disability and Autism Strategic Lead for North East London. So I cover the 7 North East London boroughs, and I sit in the CCG.
Thank you very much. Have we got Beatrice now? Is she still having problems logging on? Otherwise, we've got Binny who's going to cover her section. So Beatrice not here yet. Okay, that's fine. And a big thank you for VHR Training Hubs as well for hosting this, and Chi, especially to you to organize this also. Thank you. So quite swiftly and promptly we'll start because we do need to finish by 1 for people to get onto their clinical as well. Chi, would you mind just start in the slideshow, please?
So just a quick housekeeping, just to let everyone know that this session will be recorded and it will be available to watch on the Training Hub's webpage. And Chief, you can share the next slide for me. Thank you. Please, if you can kindly mute your mic unless you are speaking. Improve your bandwidth by closing any sort of extra windows and apps that you might have that might slow it down or cause the lagging. The webinar will be recorded, and if you have any questions, please post it into the chat functions and we will have a Q&A session at the end. Thank you. Chi, next slide, please.
So I'll take on from here. Good afternoon, everyone. I hope everyone can hear me clearly. So to start with, whom are we actually talking about? So who are these people? And so what is learning disability? There are various terms that float around: learning disability, intellectual disability, learning difficulty, global developmental delay, or as we knew it in the ICD-10 or the diagnostic classification system, mental retardation, which fortunately is being used less and less now. So learning disability affects learning and intelligence across all areas of life. So it's not specific, for example, having difficulties only with reading or only with arithmetics type of thing. It will affect all areas. Individual will have limitations of learning and adaptive behavior and the skills associated with it. Difficulty in understanding and retaining information. So this is especially important when we think about people with mild learning disability. And you might think, well, this is the same information I've provided to them n number of times. Why are they not able to apply it? Basically, because they have difficulties in retaining that information and translating it back into the practice. Needing help and support with some everyday tasks, and this depends on the level of learning disabilities as well, which we will go through a bit more in detail. And these problems should be evident during their developmental period, so before the age of 18 years, and it may worsen as one grows older if they have a neurodegenerative condition associated. What we really need to remember is learning difficulty is very different from learning disability. The way I remember it is learning difficulty is like an umbrella term which covers all aspects where people have difficulties in learning. So it can be dyslexia, dysarthria, and under that umbrella also comes a learning disability. But not everyone with a learning difficulty has a learning disability. That is what we need to remember. So individuals who have difficulties in specific areas, that's different. They do not have a learning disability. Next slide, please. Thank you. So moving on to the levels of learning disabilities. So learning disabilities can be divided into individuals with mild, moderate, severe, or profound learning disabilities. So if we take the IQ of everyone out in the community, the average IQ would be somewhere around 100. We have the super intellectual lot on one side towards the right, who would have IQ over 100, over 130, 140, as you might have read in the papers with young children taking Mensa tests and getting extremely high IQ scores. And on the other end of the spectrum is individuals who have IQ less than 100, and these are individuals who will need a little bit more extra support in their life. The cutoff, whether you have a learning disability or not, if we are going to present it at court, is someone who has an IQ of less than 70. And that has to be together with deficits in their adaptive functioning. So an IQ assessment in itself will not really stand ground. It has to be coupled with adaptive functioning. Anyone who has an IQ between 50 to 70 would be classified as having a mild learning disability. And as you can see, they form the majority of the population group, up to 85%. So these individuals generally can learn to read and write and do some basic maths. And when I say learn to read and write and basic maths, it's probably not possible for them to take the GCSE exams or A-level or learn to drive a car or anything like that. It's at a very, very basic level. And many adults would be able to do some type of work and live independently with little bit of floating support, such as to help with their bills and finances. The next category is individuals with moderate learning disability. So these are individuals who have an IQ between 35 to 50. They probably would need a bit more support. Again, they may be able to do basic reading and writing and can learn to have some degree of independence, but they will need a little bit more support with planning, with organization, with putting things in order, with cleaning generally in the house. And then comes the severe, which is 5%. So these individuals with IQ of 20 to 35. And we have profound, which is 1%, less than IQ less than 20. So both these groups, severe and profound, will have real deficits in areas of self-help skills and communication, and will need quite a lot of intensive input, hands-on input from carers to go by their daily life. Next slide, please. Thank you. So if we look at the population, we have 1.5 million people in UK who have a learning disability. 2.16% of adults are believed to have a LD, and 2.5% of children are believed to have learning disability. But I think the last point, that approximately 77% of these people are not known to health or social care, is very, very, very relevant. So the people that we actually see, or especially LD services actually see, is only a tiny fraction of what is out there in the community. And as primary care, probably majority of the care of these individuals is being obtained from primary care. And that's why having sessions like this is really, really important. Next slide, please. I'm not sure if Beatrice is with us. Okay, I'll carry on. So moving on to the confidential inquiry into deaths with people with learning disabilities. So in 2013, University of Bristol carried out the CEPOLD inquiry, and the findings were quite shocking for general community. I wouldn't say it was something that came out of the blue for people who are working with this group of individuals, because we do know they are a highly vulnerable group, both health-wise as well as with regards to their social side of things. So what the report found is each year over 1,000 people with LD died prematurely because adequate care wasn't provided, and 42% of these deaths were thought to be preventable and avoidable. The preventable are the deaths that could be prevented by more public health measures, and avoidable is things which are treatable. For example, pneumonia, for example, constipation. They were attributed to delays in diagnosis, treatment, and failure to provide adequate care. And since 2014, the University of Bristol have led on the leader reviews. That's a mortality review for people with learning disability. And on one hand, it's brilliant that we have these reviews, we have it in black and white saying this is a highly vulnerable group. There needs to be steps taken to make sure there's equity of care and access to care for these individuals. However, the sad part of it is, if we look at the recommendations year on year from LEADER, it comes down to the basic principles of making reasonable adjustments, communication, and breaking that barrier for these individuals so they're able to access healthcare when needed. Health problems for people with learning disability, they're 2.5 times as many comorbidities as other patients. And people with LD die 16 years younger compared to general population. So if we look at men with LD, they are on an average 23 years earlier than men in general population, and women 27 years earlier than women in general population. Next slide, please. Thank you. So LEAD, as I said, it started in 2015 after the CEPOLD report, and it was to support improvements in practice and also to reduce these early deaths and health inequalities. And we do this through supporting local reviews of deaths with people with learning disability aged 4 years and over. So for adults with learning disabilities, it's done by the LD services. And for children, it's covered under the children mortality group. Next slide, please. So why should we do a review? Is it just one more tick box exercise? And I think the statement is quite important. It says, at first I thought the review might just be a tick box exercise, but the depth of information that they asked for is really encouraging. And that they really want to get to the bottom of things that went well and things that didn't go so well. So it's a proper learning type of exercise rather than actually apportioning blame to one service or to individual about what happened. It's actually looking at both sets of practices, good practice as well as practice that we could improve. And that's the only way we are going to get it right. Next slide, please. So the LEADER program from a Northeast London perspective. So since starting the program in 2016 to September 2020, 10,029 deaths were notified in England, 1,230 were in London, and 272 notifications are from Northeast London STP. By September 2020, 165 reviews were completed, so 61%. 15% of this process is being reviewed, and 24% are still waiting to be allocated to a reviewer. And one of the reasons for the delay in completing the reviews is because of the workload. Unfortunately, we haven't received any additional resources to complete the reviews. And from a team perspective, we are all in agreement that it's absolutely necessary to do these reviews. But it does mean that we are taking a bit longer than what we would really hope for. But there are plans and processes in place to get on top of the numbers by next year. Next slide, please. So the NEL data completed reviews, out of 165 completed reviews, 147 reviews were on adults and children over the age of 14. 68% had reviews recorded annual health check, including one who was a 17-year-old. 45 of the 102 had no health action plan that was evident in the review. Not saying that it wasn't present, it wasn't found at the time of the review. 30%, so 45 in number, there was no evidence of an annual health check being completed. 18 were children under the age of 14 years and did not meet the criteria for having the annual health check. Next slide, please. If we look at the most common causes of death mentioned in the part 1 of the death medical certification for the cause of death, it's aspiration pneumonia and pneumonia that tops the list. And there has been a lot of work that has been done by the leader, the learning from leader groups regarding raising awareness about dysphagia, what are the signs to look out for, and how we could put in protection plans to reduce the risks due to aspiration pneumonia in special. Third, we have cardiac-related problems or ischemic heart disease. Fourth, we have sepsis, followed by dementia, epilepsy, and cancers. Again, I'm sure we all can reflect back into our practice and see the reasons why these might be the most common causes of death, with regards to the lifestyle, with regards to accessing health care or social care for that matter, and the take-up of screening. So there's a lot of factors which actually feed into this. Next slide, please.
Thank you, Binny. I think if we hand over to Rachel now.
Thank you very much. So that was really helpful, Binny. Thank you. So what we're going to move on to now is talking about the link between learning from LEDA and annual health checks. So I'm sure that colleagues are all very, very aware that everybody with a learning disability over the age of 14 is entitled to a full annual health check. And the reason that check is so important is it's an opportunity to detect unmet and unrecognised health conditions. So going back to what Binny was saying earlier, what LEDA is showing us is that a number of people with learning disabilities are passing away from conditions that could have been identified earlier or could have been prevented. And that's why it is so important that people do go for those annual health checks so that we have the opportunity to do that. If I could have the next slide. The discrepancies that we have there in the annual health checks. And really what we just wanted to highlight is that there are a significant number of people who have not had their check now leading up to their death. Now that doesn't necessarily mean that their death could have been prevented, but it also means that it could well have been. So there is that significant gap there, and we know that we're not reaching everybody. If I could have the next slide. And this is just to very, very quickly talk about targets. Now, I don't want to linger on this for too long because, to be honest with you, targets are great to monitor where we are. But for me, it's more about the patient than it is the overarching targets. In a perfect world, everybody would have an annual health check. So I'm not going to obsess about targets. But just to kind of give you an idea, the way that we were measured previously is the national target was that 75% of people with a learning disability on your GP registers. That was the target for health. Now, what NHSE are now saying is rather than 75% of the registers. It should be 75% of the estimated learning disability population. Now, what that has meant is that last year we fell significantly short of target, and the implication to that is that there's probably quite a lot of people out there with learning disabilities who we're not getting on our GP registers. So that's one area that we have to address to begin with. And then the other side of that is making sure that those people on registers are being offered their check and are taking it up wherever they want to. So again, if you just want to have a quick look at your borough data there, the percentage of the registered with annual health check, there is quite a bit of variance there, and we do have some boroughs that perform really well and others where there is a little bit more of a gap. So it is really just about looking at our own individual registers and thinking, have we done everything we can to make sure that people have been offered their check and been supported to take it up where they want to. So we can go to the next slide. I think, Masuma, you're going to be taking this.
Yes, that's me. Thank you. Hi, everyone. So the next few slides are around annual health check and good practices. So as you can see from this one, 45 reviews were done and 46% of completed letter reviews showed good practice. And the list shows what they were in relation to. So full physical and mental health reviews, physical examinations, observations including height, weight, blood pressure and blood tests, discussions around reasonable adjustments, mobility. Just like to say that we are hoping to run a webinar in the new year around reasonable adjustments. Medical reviews, behavioural and mood changes, review of care coordination where applicable, social care needs such as housing, employment, carers, CLDT team, support to manage own health and make decisions, consent to share information, and health action plan. Next slide, please. So this one is a snapshot of example of a good practice. You can see on the right-hand side, short little blurb there where it says from a patient, I was not sure what to expect. I was seen by the nurse and then by the GP. He took his time. I felt listened to. He provided advice on what I need to do to keep healthy. My support worker was available to tell him more. So that's just an example of good practice. So you can see from the list there, examination, full physical mental health assessment, full body examination, including sight, hearing, dental, abdominal, incontinence, mobility, observations, mental health, comment, medication, social, action plan. And if we go to the next slide, please. So a health action plan. A good action plan should summarize patient discussions with GP and show important information to the person, their goals and outcomes, including what they want to achieve. So all of those were good practices and what a good action plan should look like. And the next slide, please. So this is not an annual health check, which is, hello, how are you today? BP check, do you smoke? Do you take alcohol? Everything seems to be okay, goodbye. So as you can see, there's not a lot of information there, not detailed, very short. So this is not what an annual health check should look like. And if we go on to the next slide, please. And I believe Beatrice has joined us now. Can you hear us?
Can you hear me?
Yes, welcome, Beatrice.
Oh, thank you, and my sincere apologies for the technical itch there. We have put together 3 examples of conversations that were captured during our leader reviewing process. And the first one will look at a 33-year-old male with moderate LD and limited verbal communication. He visited his GP for annual health check, and this is a summary of the conversation. The GP host, how do you do today? He said, sorry, what are you here for today? He says, I'm here for an annual health check. And the GP has changed since our last appointment? Not really. The GP checks his BP and checks and defines it's all clear. He also checks the weight and height and records the BMI. He also looks at the patient's whole health action plan and he notes down nothing has changed. And he tells the patient, please book your next appointment. Should anything change, please give us a call. So that was the first conversation that we put together for you. We had a second one, which is a 60-year-old male, severe learning disability, a wheelchair user with a carer, and he's nonverbal. And the GP asks, how is BP today? The carer says he's fine, but occasionally complains of abdominal pain. The GP goes on to say, I can see was seen 10 days ago, prescribed Dupalax. Is it helping at all? The carer says he's opened his bowels and seems okay. So the GP checks his BP and the patient was a little bit resistant, so he wasn't really cooperating. Can I do your appointment? The GP asked. The patient nods no. The carer says he doesn't like being touched. Then the GP notes down patient declined examinations. He further goes on to say, I'll send you to the hospital for bloods, and I'll see you in 2 weeks with the results. The third patient is a 55-year-old female, moderate LD, with a family carer. The nurse sees the patient first, and he asks the patient, how are you doing? The carer says she's okay, but not sure. There are some changes in her moods, and she's not sleeping well at night. The nurse asks, is she eating okay? The carer says yes, but sometimes not good. So the nurse checks for BP, for weight, and he says, wait to see the doctor. When they go in to see the doctor says, oh, your BP is slightly high, and your weight has gone up. Are you still taking your BP medication? The carer says yes. What about your exercises? The carer says, not always, but with some support when the support worker is available. Then the GP says, you need to do more exercises and check your BP regularly. The GP also notes that the patient was overdue for dentist and optician appointment, and he says, book an appointment to see your dentist and an optician. You also asked, I've not seen your returned bowel screening kit, and I can also see you declined an appointment with a nurse. The carer says, I sent the kit today, but if you remember, GP, the last time we agreed PC would not be having a cervical test. She's not sexually active. And the GP says, okay then, I'll see you again soon. Clearly, from all these conversations, we can see some inadequacies in it. There's no consistency in terms of obtaining more details about the patient's health. The GP is addressing the carer, not the patient. We see no physical examinations or mental health examinations and no medical reviews. We see no attention paid to the social care issues, mobility, adaptation, or reasonable adjustments, and no health action plans. Next slide, please. What actually these three examples and more that we were not able to pull together in this example are that we have seen short appointments which are being provided of 10 minutes or less. There's lack of flexible appointment times. There is poor quality checks as demonstrated in the slide above. There's no proper mode of communication, declining screening and refusal examinations by patients, and the GP doesn't do much more. We also see that different doctors each time. Carers are not allowed in consultations, and that was picked up in some reviews. Family members being used as translators. We also see no blood tests sometimes, and those that refuse blood tests, nothing much is done. We also see patients who do not attend appointments and no further follow-up, and plenty of these reviews did not have health action plans. So what are the barriers to good quality annual health check? We picked the 6 common barriers, and the first one was overshadowing diagnostics, where symptoms are wrongly assumed to be related to the LD condition. We also saw gaps in communication, prejudice. There was also lack of awareness of the needs of people with learning disabilities. We recognize GPs do not have GP alerts on their IT systems, which remind them to recall patients for regular annual health checks, and physical environment, which varies from crowded reception areas to small consultation rooms, plus many more. So what needs to improve? All patients who are known to have learning disabilities aged 14 years and over should be offered an annual health check. We should provide our patients with longer flexible appointments and ensure our waiting times where appropriate are short. We should also improve communication and provide suitable modes of communication such as easy read, interpretation, or translation services as needed. We should also look at holistic assessments, not just immediate clinical needs. We should provide them doctors of choice where possible. We should also consider home visits for unbound or poor mobility patients. GP alerts to remind GPs when patients are due for appointments is very good. And we should also provide follow-ups for missed appointments for those patients who don't turn up. We should also provide support for patients who are afraid of injections. There's a needle phobia, and this would help them tolerate needles more easily and accept blood tests. Close working relationships with community LD teams to support patients is also very, very important and needs to be improved. Bini, next.
Thanks, Beatrice. Chi, can we move to slide number 23, please? Yeah, thank you. So moving on to the COVID-19 situation in Northeast London. I know all our services changed overnight from March onwards. So first cases were reported in UK, as we know, in late January 2020. And in our patch in Northeast London, the first learning disability COVID-19 death was recorded on the 17th of March 2020. And if we follow the graph from there on, quite similar to the national peak, we had our peak in April, where we had 36 deaths in people with LD. In total, 43 cases were recorded by the end of May 2020. And what we did with LEADER during that time is where we paused the full reviews, we did something called as the COVID-19 rapid reviews, to capture any learning and to make sure that the learnings are then converted into changes into. Next slide, please. Thank you. If we look at the health conditions that were associated with individuals who had contracted COVID-19 and unfortunately did not survive, it was very similar to that seen in general population. So obesity topped the list with type 2 diabetes, hypothyroidism, kidney disease, respiratory conditions, heart condition, and as we all now know, Down syndrome. So Down syndrome has now been added on as a vulnerable condition, and individuals with Down syndrome did get the shielding letter in the second wave now. And also cancer in those aged over 70. Effective management of these conditions was important and key in averting the prevalence of COVID-19 amongst this cohort. Next slide, please. So what were the learnings from the rapid reviews? We learned that the symptoms were quite varied, and especially in people with learning disabilities, what we did observe that they could present in unusual ways, such as confusion, which again, now we knowing a bit more about how this virus behaves and how it can present, we are a bit more in a knowledgeable position. But back then in March, we weren't. So symptoms varied. 90% of cases died in hospital. There was a variation in the length of stay in hospital from a few hours to weeks. What we also learned that there in quite a few number of individuals, there was a delayed presentation to hospital and there was acute deterioration in their presentation. There were also some problems when individuals were discharged, especially during the early part of the pandemic, or community teams not being notified, homes not being notified, which then had a domino effect in care homes. Personal protection equipment, again, in the early stages of the pandemic, was challenging. There were also concerns regarding the application of Mental Capacity Act and also the DNA CPR orders. We know when the pandemic started, and with regards to end of life guidance, the clinical frailty score was quite unfair towards people with learning disability. It was challenged by MenCap and it was reversed. So it was said that it should not be used if the individual has a learning disability because it just puts them in a back foot to start with. And also application of public health guidelines. There were so many guidelines coming out during that time. And it was about adapting all those guidelines to make sure that they meet the needs of this group of individuals who are highly vulnerable. What we did notice is there was some excellent piece during the time. So 78% of the individuals who visited the hospital had a hospital passport, which is very important so that the hospital team knows what are their health conditions, what treatment they are on, what is their preferred modes of communication, and ensuring they have a good quality of care. There were excellent pieces of work done by the acute liaison LD nurses in actually supporting not only the individuals, but also their families at a very distressing time. All palliative care were recorded as received excellent care, and GPs and professionals within the LD teams quickly adapted to the new ways of working. So changing from our routine face-to-face appointments to phone calls, video consultations, doing consultations, putting on the PPE, it was a huge change, but there were some really good pieces of work. And thank you all for actually supporting this group during these difficult times and continuing to work with them. Next slide, please. I think I'll hand over to Jyoti from next slide.
Thank you, Vinny. And I think this section is where most of the questions are coming actually. But I'll just go through the new national guidance that's come through. As you would know, a lot of the DES and the QOF work is kind of suspended, but there's a clear message coming out from NHS England that the annual health check must continue, because these are the vulnerable patients, these are the at-risk patients, and we need to provide them care, particularly in relation to the leader finding. So the guidance is to continue offering the annual health checks, but you can use this hybrid approach. And we talked about even in the chat about having a questionnaire sent. And certainly in our practice, we would send questionnaire on getting some basic information like smoking, alcohol, etc., the data. Then we would give them a call to do all the basic checks about any issues that they have and to talk about any reasonable adjustments, who's the carer, and getting all that sort of softer sort of information. We then bring them in to do a more targeted investigation or examination, really. And that could be a blood test, which we tie in with the checks, or it could be just a baseline health check, as you would do for any 40-year-old or any 25-year-old Asian who requires HbA1c, etc. It is expected that you consider these at high risk. And again, there's a question in the chat. but you would take precaution for any high-risk patient in terms of the infection control. So carry on doing that in a COVID secure way. Next slide, please. Okay, so this is just what NHS England is sort of suggesting, and actually I found this, I've used it in the last couple of weeks with my patients, and I actually find the process much better, even to actually carry on post-COVID, whenever that may be. And this is again going to that framework and questionnaire that you could actually locally develop, or we could share some of the questionnaires that we've used with the team and try and have that NEL approach, whichever works, but then have the face-to-face appointment. And it doesn't have to be with the GP, it could be with a nurse, it could be with the HCA, and it, again, depending on individual situations, really. Next slide, please. Okay, so this is the guidance of who do you prioritize. We know most of the practices do tend to do all the checks in the last quarter, essentially, which is why some of the figures are appearing low. But the advice is that you try and target people that haven't had AHC last year, people that are overdue with multiple comorbidities and have had recent admission. That actually, if you look, is a huge cohort and actually technically could cover all the patients on in this on your registers, essentially. Thank you. Next slide, please, Jane. Okay, there are a couple of things that have been sort of added and advised by NHS England to add is the flu vaccination, which hopefully we're all doing, and actually making those reasonable adjustments for people that can't come out or whose family are not able to bring them out to actually do home visits. Equally, for people with needle phobic, a lot of the learning disability team nurses locally should be supporting with this sort of work. And I absolutely recognize that we really don't have that robust pathway and team working. But I'm hoping as the DES and the QI element of quality of the learning disability progresses over the years, that teamwork will absolutely be seamless in terms of making sure that we get the right outcome for these patients. And the other thing to record is the ethnicity, again, going back to risk assessing these patients. Next slide, please. I'm going to hand over to Rachel just to go through the actual DES requirement. But as I said, the only difference is that the COVID one can be a blended or a hybrid sort of model with virtual and targeted sort of approach with the examination. I'll stop there and pass it over to Rachel.
Lovely, thank you. So this is really just a reminder of what is within the DES, because as we are moving to the different ways of working that Dr. Sood has outlined, and we are looking at blending virtual and face-to-face, it is just really important to remember that whatever methodology we use to meet with people, that we are still meeting all the requirements of the DES. I'm sure you're all very, very familiar with that, but as a minimum, a health check does need to include all the elements of health promotion. So looking at chronic illness, physical examination, epilepsy, dysphasia, where they're applicable, behaviour and mental health, particularly at the moment, we know that a lot of our clients are finding the regulations and rules around lockdown very, very stressful, as the majority of the population is. So that is a really, really important element of the check, and specific syndrome check, again, where that is relevant. We do ask that we check on the appropriateness of prescribed medication. We are doing some work around STOMP, which is stopping the over-medication of people with learning disabilities. So that is another really, really important feature of the check. Reviewing coordination arrangements with secondary care, transition arrangements where appropriate. So again, that's your 14 to 25-year-old cohort, and just making sure that they are being supported through that period. A discussion of likely reasonable adjustments, or if there is secondary care needs identified, making sure that the person is able to access that in a way that suits them. Looking at communication needs, particularly thinking about how the person may communicate pain, and also spending time thinking about the family carer needs. And finally, just again to stress that another really, really important element of the DES is making sure that health action plan is completed at the end of the check, because there's no point in doing a wonderful, perfect check, but then not implementing the actions that you need to do to improve the patient's health. So just please do remember how important those health action plans are. Next slide, please. Good. Thank you. And this is just to highlight some of the key learning interaction things that we identified as part of the LEDA review. So obviously improving the uptake and quality of annual health checks is one of those, which is one of the reasons that we are here today. Stopping over medication, as I mentioned earlier, is another key work stream, and I'm sure we'll be delivering something further on STOMP for you all in the future. More LD awareness training to all staff who are working with our clients with learning disability and also autism. Strengthening collaboration, information sharing and communication. So I see there's a lot in the chat about that, which we may pick up in the Q&A, but we do recognise, as Dr. Sue said, that there are pathways that we do strengthen and improve across NEL from both sides to make sure that we are providing the best wraparound care. Access to community crisis care and also effective ways to accessing rapid diagnostic assessment. So those are the recommendations that came out of the letter review, and there is a link within the slides if anybody wants to read the annual report in a bit more detail. I think that brings us to the end of the presentation. So we've got about 10 minutes for Q&A.
Thank you. Thank you so much, Rachel. And just to say that actually there are further webinars in a couple of weeks. We've got the QI element. Then in January, we've got the MCA and best interest webinars that would actually tie in nicely with this, and a lot of questions that are coming through. So I'm going to go through some of the key questions here. Shahid, as always, lovely questions there. Do you want to come over, Shahid, and ask the question about the coordinating the work between the LD team and the practices? So we have been, Shahid, are you there?
Yes, I am.
Yes, thank you, Shahid, for putting that question, because actually, for me, that is the key question, is making sure that that LD team and the practices have that wraparound sort of provide that wraparound service and care to that individual patients. We are completely working in silos at the moment. It's not helping any part of the system at all.
You know, can I just say,
Shahid, yeah.
I do not even know how many of my LD patients get any input from my local LD service. The communication is that bad. And there are quite a few that I'm managing on my own, and that they have come to the attention of the LD service because I put in a safeguarding alert regarding one or two of them. But you see, that's the problem. We're working in parallel universes. The other broader question is, I've been to many meetings like this pre-COVID, back in peacetime, where the problem is, you see, the reviews, when they're done, nobody ever asks the GP practice about what the logistical problems are. And, you know, there are certainly those with the ones who are in their own home or with family, there's never an issue. You call them, they come down, they get the assessment, it's done. But the problem is with institutions that are carers, which are increasingly small mom and pop operations, there are significant problems about when the availability of the carer, not about the person themselves. And they say, well, we can't come down at this time, we can't come down at that time. We are offering flexibility, but they make it so intransigent that about what times they'll be seen. It just never gets done. I'll hold my peace there.
I think you're on mute, Dr. Sood, sorry.
Sorry, Shahid, point absolutely, as always, well made. And as a team, we are completely sighted on that massive issue, which we were hoping would be sort of highlighted through the DES review and the LD health checks. It's now the approach is slightly different. Vinny, do you want to come in there in terms of involving the local LD teams and the support giving to them? We absolutely understand they are understaffed as well, but it is a wider issue about how we make sure that we get to a point that everyone knows, you know, the whole team should really share information, and they should contribute also to the annual health checks. It's quite disgraceful that, you know, we don't know who's under which team. Vinny, do you want to just comment there? And I'll stop then, move on to the next question.
Absolutely, Jyoti, I completely agree with you. From a NELT perspective, and I've seen Sanjay, so I'm sure Sanjay can speak from an ELT perspective as well. So from a NELT perspective, I would say that our nurses' health facilitation is definitely one of their roles within their nursing role in LD teams, and supporting our clients to have annual health checks and to ensure they have the right access is a priority. So I would strongly recommend that if you are having any difficulties, more than happy to actually bring that to my attention and I can follow it up. But the teams should be supporting these individuals. In all 4 boroughs, the nurses are allocated GP clusters. So I know in Havering we have 4 clusters, and we have LD nurses allocated to each of these clusters, so almost like link workers. Similarly in Redbridge, Waltham Forest, and Barking and Dagenham. So I think in the guidance that has been provided as part of this training as well, there are named contact details for each of the teams in each of these 4 boroughs who would be your contact people. Again, we are trying to improve that communication within
No, but
teams.
hang on. You can't keep on hearing this. Try to communicate to improve the thing. I mean, the most basic thing as a GP is if I send someone to secondary care, right, I expect a letter back. If somebody is attached to a particular service and is under their care, I expect a basic communication back, and even more so for this vulnerable group of people. So this idea that somehow that somebody's in a parallel universe where nobody knows the power of speech, right, and they can't communicate the fact of which caseload they have is pretty deplorable, really.
It should not be the case, Shahid, and that's why I said I'm more than happy if you can just email me the details. I will follow it up.
But how do
Also,
I know who's on there if you don't tell me? I can send the whole list. I've tried to reconcile this over many years before. I know I've got 20 people, but I don't know how many of those 20 people are actually under NELFT or not at all.
Well,
Shahid, I'm really sorry. I know you feel quite strongly about it. I think all the GPs on this call absolutely feel strongly about that point. But can I reassure you, it's something that I'm absolutely looking at, and I will make sure that each area, at least if nothing, recognizes its team and agrees a shared understanding of how they can work together. I can only reassure you that that's absolutely a top priority for me, and I will make sure that that does happen. In the first instance, I will share the details, and we'll take it back to individual teams. We've heard your point loud and strong, Shahid, and we absolutely share the sentiments there. So thank you for that. I
just wanted to add one more thing to that. We have started the advice and guidance in Havering. So again, that's a link between GPs and secondary care. It will be rolled out in Waltham Forest, Redbridge, and Barking and Dagenham as well in the coming few weeks. So as soon as it's rolled out, I will send the letter out saying that it's up and active. So please do kindly use that to communicate with the LD teams.
Thank you, Vinny. Vinny, we also have a question about blood test and doing blood tests in patients who are going to get quite distressed. Do you want to just make a comment on that?
Again, LD nurses actually do quite a lot of work. I know it's very varied across the 4 boroughs. It's not the same uniform, and it comes down to where the resources are available. So from a Havering perspective, I can say definitely that yes, our nurses are involved in taking bloods in the community and doing that desensitization piece of work. And the similar pieces of work are done at varying scales across all 4 boroughs. But again, if there is a difficulty in actually any particular patient, do notify the community LD teams. It is the responsibility of the LD teams to make sure that we actually do those reasonable adjustments and put in that health input.
I was just going to say about the GPs, just do your work and let the other things for other agencies to do it. If there's any problem, they will come back to you. There's no point about moaning all the time. Just do your work, that's all.
Okay. Sorry, I mean, I think, yeah, we can absolutely do the work, but I think it really helps to have that joined up approach to try and improve the outcome. I agree. I don't think I mean, looking at the figures, most of the GPs do the annual health check. So thank you for that. We've also got a question about the appointment time for health checks, and that's from Susie. So, sorry, somebody's speaking it. Susie, you had a question about the appointment time, and I think it.
Hello, can you hear me?
Yes, sorry, who is that?
Sorry, my name is Rana.
Okay, hello, Rana. You want to ask a question?
No, it's just, you know, these webinars and things are really good and very detailed, but when somebody brings up a question which they just want to get to the end of the thing and actually be practically doing the things, then somebody comes back and says, you feel very strongly about this, or you're moaning about this. It's not about moaning or anything like that. We just want to actually get the job done in an efficient manner. So, you know, I just sometimes then you feel like you shouldn't even ask the questions because somebody's going to come back and say, no, please, just, you know, you're too strongly saying what you need to say, and we really just want to get the jobs done.
Yeah, I can assure you, I don't think it was a member of the learning disability team that
No, I know
made
you,
that
it
comment,
wasn't. I'm just saying.
but yeah, I
It would be
absolutely.
nice to be able to be free and say, look, I'm finding this frustrating. Can we just get the teams together and actually work on this? Because, you know, these webinars, they take time to hear, to listen to, you know, because of so many things have to be put on hold while you're actually an hour or so of listening and taking it in. And then if we can't put it into practice because we can't say what needs to be said, that's not very nice.
No, I absolutely agree. And the webinars are here to try and bring up these very issues, to try and find what, you know, what people are finding challenging.
Yeah.
And I'm absolutely keen on making sure that that sort of, I know it's a word, but it's that seamless care for patients. And we've seen the effect of not providing that care through the letter review. Now these patients suffering. So absolutely.
Thank you.
No, thank you for that. I think we've just got about a minute. We have lots of questions we will capture and try and respond. And I plan to share a booklet, learning disability booklet, that we can have all the Q&As on. But if there is any last minute question, I hope I've been able to answer quite a few through the chat function. Just to say on the blood test, you request a blood test that you would for any other patient of that age or specific symptom specific. So if you've got a 25-year-old, as NHS health checks would say, if you've got a 25-year-old Asian, you do the diabetic check, you do a cholesterol if they're over 40, you do the cholesterol and diabetes for the others. So you do as you would the blood test if required based on the symptoms. So there isn't a series of blood tests that I would say that every patient 18 or old should have just because they've got LD. You treat them equitably as you would the others. And just to say, there is an acronym for reasonable adjustment, which is called TEACH, which is time, that you allow enough time for the review to be done. You make sure the environment is conducive. So if they've got anxiety coming into, I don't know, a busy surgery, you try and adjust that. You try and make sure your staff have got some awareness of learning disability and how to manage it. So that's the attitude. And it's the communication. The next bit is how the patients communicate. And this is all part of the new template that's now on the GP system that would allow you to capture that reasonable adjustment. And the last bit is help, i.e. when they come to the practice, what help do they need to have this annual health check or any other appointments? So I will stop at that.
Can I just ask one more question, please?
Yes, okay, go on.
Just one thing, you know, the updated template for the health checks, my GP was asking, so I was just wondering, can that be forwarded, please?
It's on the, when you say, is it the new annual health check template? Is that what you're referring to?
Yes.
It's actually down on the GP systems now. I've been using it for the last couple of weeks.
No, it's, because he said to ask this question, so I'm just asking on his behalf.
Well, as far as I'm aware, it's been sort of shipped through a space into our GP system. So we all should have it in the GP system. And I think it's called Learning Disability Annual Health Check. Or something like that, or NHS England health check, or
But
something like that.
It doesn't come directly into the system. It has to be uploaded or something like that. So
that's right. Okay, so you want to know the process for that?
No, I just want to know the updated template, so then we can do the rest.
Okay, I can get further details on how you can download it onto your systems. That's fine. I'll take that action away. Thank you.
Thank you. Thank you.
Jyoti, it's Rami. Is it okay for me to say
Rami,
something?
hello, Rami.
Jyoti, first, let me say thanks for organizing this, because I think this was something which was long waited, and I know it initiated quite a few discussions, which is also quite healthy. It shows that everyone over here trusts each other if we can be so open about our expressions and the problems. And I think my only suggestion would be is that, yes, I have in the past asked about list conciliation with the learning team to see do we have the same people on our registers. So could that be done at the PCN level to start off, and then to each of the practice, because I don't know the workforce. So I leave it that in your safe hands. But thanks once again for bringing this, and the number of people logged in shows that how everyone feels that they can bring the improvements, and thanks for pushing it forward.
No, thank you for that, Rami. And just to the QI element, which is in the next couple of weeks, would cover that, and absolutely cited on that. Yeah, no. So hopefully Also, we're doing a little pilot that I'll talk about in terms of the QI, and part of that pilot is actually having the LD team come in like you would have a palliative care meeting, but actually the LD team to come into the practice to discuss the LD patients that they're worried about, or you're worried about, or you're finding difficulty like blood test or screening, etc., where they can help. So that's a pilot that we're running in Redbridge, and I'll share further information at the next QI. So thank you all for coming and for putting all those wonderful questions. And it absolutely, makes my job, worth doing. I really want to try and get this right. I'm really passionate about this area. So thank you all for coming and spending your time listening to about LD. Hopefully we'll all together improve the quality of care. Thank you.
Thank you very much. It was very good.
Thank you.